Hey everyone, this is Katie Dabrowski with Old Bull Athletics, and I'm here with Dr. William Bonner. One of our passion points and thing that we just care so much about at Old Bull is not only providing our clients when they're in the session with us a different kind of healthcare experience than they've ever had, but also having a network of people that we trust when ultimately we have to refer out or ultimately we need help with some of the cases that we're working on. That's exactly what Dr. Bonner is for us at Old Bull Athletics. And if you've worked with us at Old Bull before, you know we do things differently. You know that we prioritize movement and strength, and we really prioritize creating a positive experience with those things and utilizing exercise and maybe not rushing to a surgical approach or not rushing to very invasive methods when we're dealing with pain and injury. And finding a physician who understands that is incredibly important for us. And that's what we have with Dr. Bonner and his practice. So Dr. Bonner, can you tell us a little bit about what your specialty is, what physical medicine and rehab is from a physician standpoint, and what some of your, like what makes you tick, what gets you excited about being a physician in your practice?
For sure, thank you, Katie. So physical medicine and rehabilitation is a specialty that's really been focused from its early days on the function of patients. It was developed to help restore function in injured workers and also injured soldiers around the time of World War I and World War II. And that translates today into us helping people restore their function whenever they're injured, very frequently with common pain injuries like back pain, neck pain, any kind of joint pain, and really using all the treatments we have available to us to help these people restore their function back to normal or even better than it was before. And I'm unique in this aspect because I'm really a third generation physical medicine physician. So my grandfather was a physical medicine physician. My father was also a physical medicine and rehabilitation physician. I have 4 uncles in the field, and I even have a younger brother who just recently completed his fellowship training. And so I have a kind of family connection to helping injured athletes and workers get back to their full function and maximize their training and ability as best as they can.
I didn't even realize you had that many steps in the lineage of your, it shows your passion for healthcare, to say the least.
Yes.
And something that Dr. Bonner and I collaborate a lot on is you know, when any of us at Old Bull kind of get to that point where we know we need a second opinion or we know we need some more information to help us with our decision making for our cases, and then kind of conversely in a vice versa manner, when Dr. Bonner is looking to be able to give his patients that healthcare experience that's very active and movement based. One of the biggest pitfalls we would say in the physical therapy realm is just a lot of very underdosed exercise prescription, and as we're sitting in front of these huge dumbbells, we have a lot of options for loading people and helping create resiliency. Our practice and your practice is very much based on how can we get people doing the things that they love? How can we get people to realize that having a pain or an injury does not mean that you have to stop doing things. It does not mean that your athletic career is over or your ability to lift weights and to run and to jump is over. And we're really trying to basically just dispel any of those myths surrounding training, rehab, pain, and injury, and help people realize there's a lot more you can do after injury. Can you talk a little bit about, you know, there's a lot of similarities and overlap between what an orthopedist would do and what you do, and then kind of on the other end of the spectrum, orthopedic surgery and things like that. Can you discuss what makes your practice different and some of the treatment modalities that you utilize that are a little bit more conservative management based? Can you talk about that for us? Yeah,
of course. So typically when I see a patient and I'm trying to help them get through a painful episode or some kind of injury that they're having, the treatments that I utilize, often number one is physical therapy. So I'm referring people to physical therapy, or if they've already been doing physical therapy, I'm evaluating the types of exercises they've been doing and helping them try to modify them to tolerate them or to progress them from their condition. Number two is using medications. That's one thing as a physician I have at my disposal, is I can prescribe any number of medications to try to help people get through painful episodes, whether it be anti-inflammatories or muscle relaxers or other types of medications that help with specific kinds of pains. Typically, we're using those to control symptoms while we're progressing the rehabilitation program and while we're giving them time to just kind of naturally heal on their own. And number 3 is injections. You know, I have specialized training. I did a year of fellowship in image-guided interventional care, so I have fluoroscopy or X-ray in the clinic to help me guide needles into specific structures and deliver injections. We also have ultrasound in the clinic that we use to evaluate different peripheral joints and to target specific areas with injection care. Those injections can be anything from typical cortisone or steroid injections that many people know about to anything like platelet-rich plasma or stem cell type injections that are more in the bucket of regenerative medicine people like to talk about these days. And so we utilize all of these things within our clinic to help people get back to their maximal function.
Yeah, and as somebody who constantly refers people and actually has utilized your services myself, I can speak to just the breath of fresh air going into a physician's office and not feeling that kind of pressure to, oh, well, you did this because you're just doing too much and I think you should stop. Or don't you know that running is bad for you? Or don't you know that all of the weights that you're lifting is just damaging your joints? Stuff that we hear time and time again, and stuff that we're trying so hard to kind of undo those narratives when people come in and talk to us. And having people who get it on your medical team, it just matters so much. And one of the biggest things that we deal with here as physical therapists and as trainers and coaches is talking to people about the question of like, oh, should I get an X-ray or should I get an MRI or should I get imaging of some sort? And something that we work a lot on is part of our training as physical therapists is to rule out red flags and to know when imaging is necessary or not. Can you speak to especially like low back pain? I think that's the thing that people are most fearful of. And it's almost like the knee-jerk reaction. As soon as somebody has back pains, people think that they need to immediately get an MRI. Or they also think that it's like an immediate medical emergency if they're experiencing back pain. Can you speak to like when it's actually necessary to get imaging for back pain and when actually it wouldn't be and you can continue to resume activities safely? Can you speak to that?
Yeah, definitely. You know, there's certain red flag sign like you mentioned, and so we look for those things right off the bat. If there's any history of significant trauma, we definitely want to get some imaging just to make sure there's no significant fracture or anything like that. If there's a significant history of cancer, we really want to make sure a patient doesn't have a new cancer formation. And then the other things that we look for on the history or the physical exam would be new significant numbness or weakness in a limb. So maybe your arm becomes very weak and you can't lift it, or you have a foot drop, or your leg goes entirely numb. You know, we really want to know about that, and we want to get imaging in those cases. And if there's any loss of control of the bowel or bladder, that would really indicate significant nerve compromise. And this is kind of very rare in the sense that, like, out of 100 patients who come in with low back pain, for instance, there might be 1 to 2 of them that I really think we really need urgent imaging to make sure we're not looking at something more significant here. And otherwise, I spend a lot of time counseling people on the fact that we really don't need an image because it's not going to change what we do about this, right? When you have acute back pain, we're typically going to take a little bit of relative rest. We're going to move as tolerated. We're going to take some medication if we need to help with the pain, and then we're going to work back into our normal activities and our normal exercises we see fit. And if we're not getting better, we're going to do other things. But most of the time, we don't need to get imaging. Obviously, in older patients is another thing we want to consider because they're more prone to fractures. So when people get in their 60s and 70s, and if they have a history of osteoporosis, we want to get some x-rays in people like that to rule out fractures. But I have this conversation on a daily basis, and many people do come in saying that they need an MRI to see what's going on. And I just tell them my own story that I had back pain in the past. I had back pain that radiated down my leg, and I never once got any image because I knew what the problem was when it came up. It was very likely I had a disc herniation of some sort, pressing on a nerve in my back, and I know what the treatments are for that, and I knew that I wasn't getting surgery for it. So I didn't need to see what it looked like. I just knew I had to do certain treatments to help it feel better. I took a little bit of medication. I did physical therapy exercises that I knew to be helpful for this condition, and over a few weeks to a month, I recovered significantly. The pain recurred a few times, but I knew what to do each time I had it, and over the course of 8 to 10 years, the pain was completely gone, and I'm doing totally fine now, and I still don't know what my lumbar spine looks like. And so I just tell people that story because I try to practice what I preach, and I think it is important for us to not get images if we don't need to, because the other thing happens when you get images is you see disc herniations, and then people start to worry like, well, what is this? And a disc herniation is often just a normal finding on an MRI. If we take 100 people in your age group with no back pain, we're likely to see 30 to 40% of them have some significant disc degeneration, disc herniation, a little bit of arthritis of the small joints in the back, and a lot of that means absolutely nothing to your health, to your future prospects of being healthy, to your future activity level. And so we just don't even want to think about those things. And, you know, we can always discuss these things in person, and each case is different, but in general, you know, there's a lot more imaging ordered for low back pain than probably needs to be ordered, and we as practitioners can do a better job of kind of explaining to patients the reasons why we don't need to do those things.
Yeah, I love that you brought up just the likelihood of seeing these things in asymptomatic people too. Yeah. We have that conversation all of the time. If you're going to take an MRI of anybody over the age of 25 or 30, you're going to start to see these things. And the stuff looks terrifying. The words that are used, degenerative disc disease, yeah, and all of these things, they sound like, you know, these life-threatening conditions. And as Dr. Bonner mentioned, like the vast majority, like an absurdly high proportion of these cases are not at all medically emergent situations. Not to discount the fact that back pain is not fun. It does not feel good. No. It does feel scary because it's something that we're so conditioned to be concerned about, but so much more of it is exactly what you were saying. Sometimes it means dialing back some of your intensity in your training, but a lot of it, what it also means is finding all of the things that you can tolerate and still try to maintain some level of activity and fitness. Movement, blood flow, muscle contraction, strength of our muscles, gradual exposure to the things that maybe we don't tolerate that well to in the first place. That's kind of the recipe for how we get this stuff feeling better. And then there's absolutely cases when, yes, medication helps, or yes, injections help. But by and large, it's so rare for these cases to actually require surgery. The beauty of working with providers who understand that too is if you have a consultation and you are told that surgery could be an option, you know that it actually is the reality of the situation, and you're not being pushed to do something that maybe don't need. This isn't to say that surgery is bad or never warranted. There's always situations when it is, but so much of the conversation is individually looking at you as a human and understanding if this is the right procedure for you or if this is the necessary thing for you to do.
Yeah, I think like just it's always got to be a nuanced discussion about all of these things. And so if you can't tolerate running and you love running, well, let's figure out what you can do and let's get you doing that in the meantime while we get you back to running. And these are the kinds of conversations that you have every day in a place like Old Bull in my practice, where you'll sit face to face with a physician for at least 20, 30, 40 minutes sometimes, and we'll discuss all these little aspects of things and how to get you active and keep you active while you're recovering from whatever injury it is. And it's, you know, it's just like you said, we don't want to be telling people, no, you can never do this again. No, you can never do this again. That's the easy thing for me to say. I could say, don't ever do that again. I'm going to walk out of the room. We don't want to do that. We want to say, okay, look, you have a marathon in 6 months, but you can't run right now, which you've sent me some of these patients. And so
you crushed the Boston Marathon,
right.
We'll say.
And so yes, we have to figure out, okay, what can you do? What can't you do? And then let's work you back into it appropriately. And it just takes a little bit more time and a little more thought on our part. But these are the important things we can do for people who are very active and set fitness goals, just like I know you set fitness goals. I set some fitness goals at times. So it's, you know, these things are important to people like us.
And the realization that humans are incredibly resilient, I think that's what is a defining feature of our respective practices. Like, we're creating strategies and tools for you to help manage the rest of your life with just the understanding, like, as a human being, you're going to experience pain. we're going to experience flare-ups from injuries. We're going to experience injuries, and we can't necessarily stop those things from ever happening. The example I always give is I can't stop somebody from walking out the door and stubbing their toe. Like, injuries can happen, but we can create a body and a mental system that's so resilient that your tissues can tolerate this stuff and maybe recover faster, but also your brain and your psychology can understand that not all pain and injury means this is the end. Not all pain means harm. Not all pain means tissue damage. A lot of these things are just part of being a human, but the more resilient we are, the more muscle mass we have, the more aerobically fit we are, the more strategies we have in our conservative toolkit to help us, the better we can be. What would you say are some of the biggest misconceptions about maybe a particular injury and what the outcomes are, or a particular activity that people say is dangerous, or just pain and injury in general? What are some of the biggest misconceptions that you would like to kind of clear the air on for your patients and for our community?
I think you hit on one right there, is that not all pain is doing damage to your body, okay? So that is something patients should know. Sometimes a little bit of pain is okay, as long as we know we're not causing a problem or worsening some type of tissue damage that may be there. Number two goes back to disc herniations. Disc herniations are not the end of your life. If you have disc herniations, it's okay. It just means that you're surviving and getting a little bit older, and we can work through those things. I tell people they're just like wrinkles on the skin. We get them as we get older, and you're going to be fine. We're going to get you through it.
You're sitting with two people who have had disc herniations.
Right, exactly. And we are here, and we lift weights, and we are active and can walk around and talk to people. Number three is knee meniscus tears. That's one where I get people who come in all the time, say, I have a meniscus tear, I think I need to get surgery on it. It's like, hold up a minute here, because we know now that many meniscus tears require no surgical intervention to get better in terms of any pain related to them, okay? If you have a large meniscus tear that's stopping the movement of your joint, yes, often that may require a surgery to repair it, but otherwise there are many, many, many meniscus tears that are similar to disc herniations, where if you just get MRIs of people without knee pain, you will find meniscus tears, and they're no big deal, and we can go on living with meniscus tears and be just fine going forward. So, and another one along that line is sometimes small issues with the rotator cuff, like small tears in the rotator cuff. Another thing that can really can be just fine to live with for many, many years. And so, those are conditions where, is surgery an option? Yes. There are many other options before you get to surgery to treat those problems. And I think, I'm biased obviously as a non-surgical practitioner, but I think it's always best to avoid surgery if you can, because you're not taking on the risks of going under anesthesia and everything else that comes with maybe inserting a camera into a joint or getting a body part cut open. So we work with great surgeons. We send people to great surgeons all of the time. But I think that avoiding surgery is an important thing for someone's health, because you don't want to start having surgeries that then may lead to other surgeries or other problems.
And with the eventual maybe need for surgery, we do know that patient outcomes are exponentially better if you're going in with stronger tissues and you're fitter before your surgery. So that's a strategy we utilize actually currently with a patient that we're working with together. We knew that a surgical intervention was the ultimate route because of the conservative methods that we had tried leading up to this point. And it's a case where it's safest for surgery to be performed. However, leading up to that surgery date, we're getting as fit as we can within the confines of what is currently comfortable for the patient, and what allows us to continue to make sure they're going into their surgery as prepared as possible. We know that at this point that outcomes are so much better if you're going in with stronger tissues, if you're going in more prepared by doing training and physical therapy first and conservative management along the way. So these are things where, to us, it's a no-brainer. Let's get as strong as possible. Let's get as fit as possible. Let's build up your tolerance to the things that don't feel as good, and try to create entry points for you to be able to live your life and move around in the way that is, the best way for you to keep being as active as you can be. Thank you so much. Those are very helpful questions.
For
and
sure.
They echo a lot of the conversations that we have with our clients all of the time. I think the number one thing that we can do, and our practices luckily support this because we're able to spend extra time with our patients, it's the education piece. It's the piece of, you know, people are so scared of pain and injury and thinking that things are wrong with them. And the amount of people who come in kind of already with this preconceived notion that we're just going to give them a laundry list of what's wrong and all the things that need to be fixed, instead of, hey, this is very human, it's okay to have pain, and we're going to create like such a robust and resilient human that you're going to be able to tackle what comes at you. I know you had a couple questions for us too. Jazz, if you want to pull them up, if you need a refresher.
No, I know. I frequently have discussions about low back pain with people and people lifting, and so you know, one thing that we commonly discuss is lumbar flexion, and this is something that's discussed in the ether of Instagram and social media all the time. And so my question to Katie was, you know, when is an exercise like a Jefferson curl really something that you utilize or is indicated for your patients? Because I'm often telling patients that are young people that are active with disc herniations, likely that are painful, to kind of avoid lumbar flexion for some time period at least while they're in significant pain. And so, you know, a lot of times I'm not kind of getting those people before any injury or way down the line from that injury, but it's always, when I see videos about specifically Jefferson curls, I cringe a little bit, but I also am one to kind of, like I said, never say never about a specific exercise, and so I'm curious her thoughts on that specifically.
Yeah, that's a great question. I think first and foremost with lumbar flexion, that's got to be like the most feared movement that people have.
100%.
Because for most people, if you do have low back pain, and I'm saying just low back pain as an umbrella, I don't care if it's a disc herniation, if it's a muscle strain, if there's a ligament irritation, facet pathology, like it could be anything. Low back flexion, lumbar flexion, bending over is typically the least tolerated.
Yeah.
So that's a pattern that we kind of just know to be true. And you can go so far in a direction of being like a movement optimist and being very, very against the idea that like lumbar flexion is bad. And you can go so far in the direction, and I think maybe push people to do it too soon. The approach that we take is we're trying to find an entry point, day one, for the least tolerable position for a patient. Again, most of that is lumbar flexion. But what is usually more tolerable for people is hip hinging and utilizing like a hip and a glute strategy instead of putting more of like the effort into just rounding and using the lumbar spine. Not that it's bad or something that should never be done, it's just more likely going to be more tolerable in the beginning.
Right.
A lot of people with low back discomfort too, something that helps them a lot is kind of learning different strategies to bend over, to pick things up, to deadlift. And that's where strengthening hips and utilizing like a hip hinge strategy can be really successful. Yeah. So finding an entry point for that with somebody in the beginning, I might not be deadlifting with somebody with a bar day one. We might be like isometrically holding a hip hinge and getting them used to like putting some stress into that area, but down the line, we're going to be absolutely getting back to that stuff.
Yeah.
When it comes to Jefferson curls in particular, if you're unfamiliar with what that is, it's basically, I don't know if you're going to be able to see me doing this, but it's basically with a loaded object, letting it pull you down and really on purpose, rounding your back to strengthen the tissues of the low back. It's an awesome exercise if it's tolerated.
Right.
And it's a great way to start people to get less fearful with loading their low back muscles and loading through that position that is fearful. I'll tell you, there's a lot of people that I would never do it with right off the bat because it's just going to be uncomfortable. It's the same conversation with deadlift form that, you know, one side of the internet says that all lumbar flexion is bad, and if you deadlift with a rounded back, your discs are going to explode and you're going to die. And then on the other end of the spectrum, there's people who are saying form doesn't matter, nothing matters, you should be able to lift however you want. I'll venture to say, especially if I'm dealing with somebody who has a history of low back pain, is fearful of deadlifting, and is pretty new to training, I'm not going to opt for having them deadlift very heavy weights in an extremely rounded position because they're probably not going to tolerate it. A newer lifter, somebody with a fearful history of this stuff, is going to tolerate a position that's a little bit more neutral a lot more. It doesn't mean one is right or wrong or bad or not bad. We're just kind of using a little bit of common sense if somebody's terrified of rounding their spine, I'm not going to make them do it with weight just to prove a point.
Right.
So that's, I think, a nuanced argument of Jefferson curls.
And that question comes from my own experience of back pain that was worse with flexion and got better with extension. And so I favored extension for many, many years and never flexed. And felt like at some point that got too ridiculous. And found eventually that, you know, really kind of doubling down on the types of things you're talking about, strengthening the hamstring, strengthening the glutes, is the thing that really kind of helped me solidify where my back would be stable and protected. And that was the thing that, you know, it took me a long time to figure out on my own, but that question comes from my own experience of avoiding flexion at all costs for several years all the time.
That's a great point too, because if we think about it from like a tissue tolerance and capacity standpoint, so we know that in 12 months, 90% of discs just heal. Like we know that. That's not even taking into consideration any sort of intervention. So if we know that to be the case, if we're avoiding flexion just for the rest of our lives, our discs have healed, and the reason it doesn't feel comfortable anymore isn't necessarily because of the disc. It's more likely because the tissues of our back, meaning our low back muscles, the joints themselves, the ligaments, what a lot of people don't realize is there's a ton of layers of muscles in the low back, and if you go years without ever exposing them to getting that stretch of being in flexion, anytime it happens, it's going to feel terrible.
I see some of these young people, and it's like, oh, I had a back surgery at 21, I had back surgery at 26, and it's like, what's wrong with your disc that like you're so prone to these large disc herniations? That like there's got to be some, and then some people do Jefferson curls and lift 225 and they never get a herniation or like they never get any damage to the disc or anything, you know?
There's so much variability.
You know.
Well, also most people doing those Jefferson curls at that intensity, they're already like super strong people. And it's like, I hate that stuff because it's not even a fair representation of, okay, well, how do I get there?
Right.
If you're saying this is okay and I'm not going to herniate a disc, but I've never deadlifted before.
Exactly. That's the problem with social media, right? Yeah.
You're just riffing.
Great. Yeah. Yeah, so I had another patient recently that was a young, active patient who was dealing with a lot of pain, mostly in the neck, upper back area, a little radiation into one of the arms, also associated with some sort of nerve-type symptoms of numbness and tingling, and after some testing and other things, thinking a diagnosis of what we call thoracic outlet syndrome. And thoracic outlet syndrome is sometimes hard to treat from my aspect because there's not like great procedures that can be done to fix this problem in a lot of cases. And so a lot of times it is more of an exercise-based solution. But I also feel like when patients go for physical therapy for this, there's a little bit of a lack of knowledge of what we need to do to get them feeling better. And so sometimes it takes them going to a few different physical therapists till we figure out the right program that really helps the symptoms. And the right program really ends up helping in the end. It's just about persisting and finding that person, kind of what we were just talking about. So I don't know if you have, it's a pretty vague topic, but if you have some things to offer on that.
Yeah, thoracic outlet syndrome, we see actually a lot of that with people who lift quite heavy.
Right.
Because there is a lot of compression or there is a lot of traction in those areas. What we see typically with thoracic outlet syndrome, clinically I tend to see people who fall in one of two camps. People who are pretty compression intolerant, meaning anything that's putting pressure on the nerve or the arterial structures and closing down the space where they run through is a very, very big symptom provoker. Or on the other side of it, people who are very like traction intolerant. So anything that's tugging at that stuff rather than compressing it is pretty intolerant. So I kind of try to identify that first, because usually exercises that provide traction for somebody who's very compression intolerant feel better, and then vice versa. So for a lot of people, if somebody has a lot of symptoms with anything like holding really heavy weights, that traction moment, or even like arms behind their back and like a barbell back squat, which would be a big stretch traction moment as well, they tend to tolerate something like a safety bar squat more, where they're actually getting some stability and compression in the position. And then again, you can kind of reverse that for finding the pattern of what actually feels best for them versus what does not. Just like we talked about earlier too with red flag stuff, If they're having more severe like arterial symptoms, meaning when we're doing testing, we can't feel pulses, that's when I'm saying, yeah, we want to do some more digging from a imaging standpoint or referring to somebody like you. More of what we see too, more of the nerve cases are a little bit easier to treat from a prognostic standpoint. And that's actually the most common. It's pretty rare that you're going to see true like arterial thoracic outlet syndrome. So we're operating a lot of this stuff on more of the nerve side of things. Another principle beyond the compression versus the distraction tolerance that I look at with people, nerves like blood flow, they like space, they like contraction of the surrounding musculature. So if we can find ways to contract the surrounding muscles of the nerves, it's usually very relieving for people. So it's pretty similar to how we would operate with most cases. I'm finding the stuff that doesn't feel good, and I'm finding all the stuff that does feel good. We're going to hammer the stuff that feels good, and we're going to keep your level of fitness as high as we can, and we're going to find the things where we can maybe modify what currently doesn't feel great. For a lot of people, it literally can be a barbell back squat versus a front squat, or maybe holding kettlebells feels better than putting something on your back right now. Also, aerobic activity, cardiovascular fitness, as I said, nerves like blood flow. There's extremely good outcomes for people who do more cardiovascular training to just help systemically with circulation and blood flow too. So those are great options in dealing with thoracic outlet syndrome.
Great. Okay, cool. And I had one more. I had a patient the other day who came in, and this happens probably 5 times a week, but where they tell me they have piriformis syndrome. And so true piriformis syndrome in my world doesn't seem to really exist that much, but I think many people get to piriformis syndrome on the internet. But sometimes people do have true piriformis syndrome, and I actually believe this patient may have true piriformis syndrome. But you know, in cases where you get people coming in and saying they have piriformis syndrome, what's your approach to evaluating them, and then maybe the highest yield exercises that you find for the nerve type of symptoms that they have?
Yeah. What I will often kind of talk with people about is, in the absence of those specific red flags that we talked about, I'm not super hyper focused on a specific like tissue diagnosis unless it's medically necessary, unless it would dramatically change anything that I would do with somebody. So if somebody's coming in with hip, glute pain, some radiating stuff going on, it could be piriformis syndrome, it could be hip bursitis, it could be a groin strain, it could be maybe some labrum pathology, it could be so many different things. By and large, when it comes to the hip, what I really care about, can you move your hip through its available range of motion with strength and control?
And when somebody has more of the neurologic symptoms, radiating down the leg, tingling in the leg, burning in the leg, do you utilize nerve flossing or other strategies like that? Where are your go-tos there?
For sure, yeah. If people are getting more of the radiating symptoms, and we've ruled out it being something that would be, medically necessary to, do some different strategies with, nerve flossing or nerve gliding is a great strategy. Think of nerves like, I think of it like a hose. If you step on a hose and the water can't get out or it spurts out, that's kind of like if a nerve is a little bit irritated and there's compression on it, the signal can't be sent that well. And that's where you get like funky nerve symptoms like burning, tingling, weird pressure. Nerves have so many different fibers that give us different sensory information that you can have a lot of different kind of strange symptoms. So one of the goals in rehab is to what we call centralize those symptoms kind of back to the origin, instead of them being so irritated that you feel it all the way down the path of the nerve. And strategies for that are absolutely like nerve flossing or nerve gliding, which you can kind of think of it like a stretch for the nerve, just like sometimes we need to stretch our muscles. Nerves need space, they need to be able to move through the soft tissues of our body. So it's a great strategy. And then I'm always pairing that again with something contraction-based, something to give nourishment, nutrition, blood flow to the muscles that are innervated by that nerve. That's what nerves like a lot. So that's where the strengthening stuff comes in too.
Okay, very interesting.
So as you can see, our practices are really aligned on being very human-centered and individualized in our approaches for people. And also, I think, just educating and making sure that people feel okay with the inevitabilities of aches and pains, and knowing that they have a team of people who are very well qualified to make people feel safe and make sure people know that movement is good, exercise is good, avoiding surgery if we can is a part of the picture. What would you say is something that as a physician that you want your community to know, you want our community to know about, like, your pillars of care and what makes you very, very, like, committed to this type of medicine?
Yeah, I mentioned my family history before, and I always tell people that I treat every patient like they're my own family member.